Awesome, awesome. Welcome everybody to Tuesday edition of VMR, and it's a POCUS VMR. I'm very happy to have a great friend of VMR, Dr. Sanjay Patel, who's volunteered to present a case today. He came on previously for a VMR early on in September, and I think it was August even, right? I think it was August or early September, somewhere around there, late August. Yeah. And before that, I remember you presented a case on a Friday VMR to Rabi and Reza, probably a year ago. I fondly remember that case too. So I'm going to ask Dr. Sanjay Patel to introduce himself.
Sure. Hi, everybody. I'm Sanjay. I'm a hospitalist and associate program director for the internal medicine residency at Riverside Methodist Hospital in Columbus, Ohio. Thank you for having me on today.
Thank you, Sanjay. And I also want to make a plug. You'll see Sanjay at a lot of these national POCUS teaching sessions up and down the country, ACP, SHM. So he's a great teacher of point-of-care ultrasound in his institution, and also to a lot of faculty members, residents, and interns and students that attend these conferences. And I also want to introduce Nikita, who I just roped in just before shortly to co-discuss. Nikita, do you want to introduce yourself?
Yeah, hi everyone. I'm Nikita. I'm a recent medical graduate from India, and I'm excited to take part in today's POCUS VMR.
Awesome. Thanks, Nikita. And Deb, I guess Leah, and who else who's doing teaching points and scribing? Leah,
so Shema is gonna scribe today, and I'm doing teaching points.
Oh, introduce yourself. Go ahead.
So I'm a medical student from Austria, and currently waiting to just before starting my year of internships. Yes. And
awesome. Thanks. Always good to see you, Leah. And Shema?
I will only unmute for a couple of seconds because I'm in a library. Yeah, I'm also a 50 medical student. Hi.
Awesome. And Shema's from Berlin, Germany. That I do know. So, all right, let's share the screen, deploy the whiteboard, and have the first aliquot.
All right. Are you ready?
Yes.
All right. So just some brief history first. Have a 44-year-old woman who comes to the emergency room after passing out. She was running late to work. She went outside. She saw the bus leaving the stop. She started running and had to stop because she was short of breath. She felt lightheaded and then passed out on the street.
Very interesting. Nikita, do you want to take a first stab at that?
Sure. So at this point, the main points I'm looking into is she's a 44-year-old female and she just passed out. So I think I'm presuming that this is a syncope and she started running, so she has some activity. So is it something related to the cardiovascular system? I don't know. So I'm just, with this piece of information, I don't really know where could I possibly locate this to, whether is it something to do with the fact that she's running late? So was she anxious? So I'm pinching into that too, but also thinking about the cardiovascular system. Is she hypertensive? So yeah, I think mostly I'm looking forward to more information because at this point of time, I don't really know where can I redirect my thoughts across to. So yeah.
Awesome thoughts there, Nikita. Yeah, syncope is a very general sort of a disorder. There's so many different causes. We can go through cardiac, neurological, we can go through volume-related issues, arrhythmogenic issues. We concentrate in the area of the cardiac region. So at this point, I mean, if I just look at age, where should I prioritize somebody coming with syncope? yes, volume orthostasis can be a common cause. And if we do determine that she has orthostasis, we correct that. Could it be endocrinological, adrenal insufficiency? Could it be carotid sinus hypersensitivity? Could it be just a plain volume disorder? If she came in with, say, nausea, vomiting, or diarrhea, or decreased PO intake, there would be a volume deficit, which we would correct, and then repeat the orthostatics to see if there's a resolution at the drop of blood pressure, 20 millimeters of mercury. At this stage, also, I'm wondering about primary cardiac disorders. So definitely arrhythmias, and also something like ACS must be ruled out. But I would look for other identifiers or associated features of this presentation to then tease out where should we really invest a lot of our cognitive energy. So at this point, yeah, syncope can be very dangerous. So somebody coming in with syncope really need to prioritize, like, can there be a life-threatening disorder? And we'll get some more information from Sanjay and see where we should go.
Yeah, absolutely. So a little bit more of an extended HPI and some background history. So a couple was walking by and they helped her up. They said she had lost consciousness for a few seconds, came to shortly thereafter. They urged her to go get checked out, and that therefore she came to the emergency room. Just a little backstory. So she had skipped breakfast that morning. She was running late to work. She did not note any injury to her head. Her review of systems was otherwise fairly unremarkable, specifically no chest pain, no palpitations, no nausea, vomiting, fever, cough, chills, or diarrhea. She has had intermittent headaches for the past 1 to 2 years, along with some fatigue. She attributes them to being stressed out at work and some underlying anxiety. She has also noticed on questioning that over the past year or so, she hasn't been able to walk as far as she used to. She is not typically active at baseline. She did in her 20s have a few episodes of passing out with some lightheadedness, and none since then. And again, she's been significantly less active over the last 20 years or so. Going into that with some background history, she's got a history of anxiety, depression, iron deficiency anemia from abnormal uterine bleeding. And in her 20s, those episodes of passing out were diagnosed as a sinus node dysfunction, and she has an AV pacemaker. She is single, lives with 2 roommates, no smoking, no alcohol, no drugs. She is a paralegal, largely does desk work for a living. Family history, she is adopted, so unknown. And medications, she is on sertraline, PRN, alprazolam, and ferrous sulfate.
All right, we can stop right there. Nikita, what do you think? Quite a bit of information here to digest.
Yeah, so with all of this, when I just heard the HPI, the first thing that I thought to myself was, okay, this person as of now relatively didn't have any subacute or chronic symptoms. So this is an acute onset of disease. But after hearing that she's someone who has had sinus node dysfunction and she has a pacemaker in place, I'm thinking towards the cardiovascular system. But also, since she's had many episodes of prior syncope, I'm thinking, what's the difference between this episode compared to previous episodes? Is there anything new that has happened this time around? Should we be worried about a new onset of myocardial ischemia? I mean, I'm mostly thinking, what is the cause of a sinus node dysfunction previously? As in, what caused them? What was it? Just a reflex syncope, or I'm not really sure. So, yeah. But also, I think I'd be looking into her medications too. Someone rightly suggested sertraline, long QT syndrome. That's one thing. But yeah, I think after hearing the HPI and the past medical history, I'm more looking towards the cardiovascular system. But I'm mostly, I'm still I do want to know what makes this syncope episode different from the previous ones, because she's got many factors that would cause a syncope. Example, her iron deficiency anemia. Is it treated? Is it not treated? So yeah, those are my thoughts for now. Very scattered, but I'm hoping that the examination would allow me to have more of a proper diagnosis.
Great job there, Nikita. Yeah, it's difficult because there's so much just sort of being thrown at us that we're trying to grab and trying to make sense of. So while you were talking, I was able to sort of start thinking, okay, where should I invest a lot of my cognitive energy? Because there are a couple of troubling features here. Started running and feeling lightheaded. Maybe the exertion there may prompt us to think about a cardiac issue, like you mentioned. Other things, there was like decreased PO intake, so that would direct to maybe a orthostatic problem, because like 20% of our fluids come from food. So if she's not eating as much, maybe she's not drinking as much, so that could highlight that. And then this not being able to walk as far as she used to, then that also then brings us back to this cardiac issue is probably the center of gravity here. But then there's a few other issues, iron deficiency anemia. So could this be, again, volume? You have volume, could be fluid, could be anemia at this age. So that could also cause repeated syncopal episodes. Vasovagal syncope is a benign cause, and I can't say common, but it's a diagnosis of exclusion. And usually what fits that is somebody who is repeatedly having these episodes where they pass out, and there's some prodromal associated signs and symptoms, diaphoresis, palpitations, taking an exam, being scared, somebody jumps out and then scares them, and that could trigger this tachycardia and then this bradycardia episode. So there's always this prodrome that's surrounding it, and it happens frequently on occasion. Sinus node dysfunction in a 44-year-old is interesting, requiring a pacemaker. I would ask then, was this actually necessary? Was the correct diagnosis made and a pacemaker placed? Or now, in spite of this pacemaker, the patient is continuing to have syncope? It brings up a very rare cause of syncope, something called ictal bradycardia, where it's found in patients that have seizures can have bradycardia. And there was a case that I listened to where a patient was having seizures and was passing out. And it was actually, I guess, or they had bradycardia, sorry. And they put in a pacemaker, but it was seizures or non-epileptic or non-convulsive seizures causing the bradycardia that needed to be treated, and not the pacemaker was not required actually to help with that bradycardia. And you're actually right on the dot with the medications causing potential arrhythmias like QT prolongation and so on. Then in 44-year-old, you start thinking about arrhythmias that have high associated mortality, morbidity, Brugada syndrome, HOCM can have that too. There's long QT, there's a few others that are escaping, but there's some arrhythmias that we should know in the case of syncope, and that we should learn to identify. Heart block, definitely. Bradycardia, you could have some infections, Lyme's, Chagas, that could cause issues with the bundles. Then infiltrative disorders like sarcoidosis, things that could infiltrate the bundles and cause something like this. Although you'd have like blocks rather than just bradycardia. So there's a few things there that I'm thinking about, but at this point I'm still not sure. But I have a lot of questions regarding this sinus node dysfunction and repeated syncopal episodes. Back to you, Sanjay.
Sure, as did we. And just to clarify, as best we could, though we didn't have any records, we talked to the patient and kind of described a variety of different types of workup. And it sounded like she had a pretty extensive workup, including some EP studies. And she was just told that she had some sort of, they weren't sure maybe it was some sort of congenital degeneration of her AV node. And so that's why the pacemaker was put in. And somebody asked in the chat, and I just want to make sure I clarify, it's strictly a pacemaker, not a pacemaker with an AICD. So the next aliquot with physical exam, blood pressure was 149/93. The heart rate was 70, respiratory rate 16, Tmax 98.3, oxygen saturation 90% on room air, BMI of 41. On exam, she's comfortable, not in acute distress. Head and neck exam, there's no icterus or pallor, normal oropharynx, eyes, cranial nerves, normal. She has jugular venous distension that is visible to the earlobe at 30 degrees. No lymphadenopathy, no thyromegaly. Her heart is regular rate and rhythm, normal S1 and S2. There's a 2 out of 6 holosystolic murmur at the left lower sternal border. PMI is displaced laterally by about 2 to 3 centimeters. Lungs are clear to auscultation. Breathing is non-labored. Abdomen is soft, non-tender, no obvious hepatosplenomegaly. Extremities, she has pedal edema to the knees, no clubbing, no rashes. Extremities are cool to touch. And neurologic exam, she's alert oriented ×3 and otherwise normal.
Great exam there. Nikita, I'll go first, it's done, but I'll tackle the vital signs and see if there's any clues in there. Sometimes there's a pattern that may be evident with vital signs. So just starting with the temperature, we do have a fever here. So this puts us into infection, inflammation, maybe autoimmune areas. So it's kind of puzzling. I didn't get a sense for any infection or inflammation from the chief complaint or HPI. So this is something that we have to put our antennas up and blinkers on and start thinking about. Heart rate, patient's not tachy, so not a arrhythmia that you would have rapid heart rate, or if there's low volume, there could be tachycardia. I don't see any beta blockers in the medication history. Sinus node dysfunction, pacemaker, could the pacemaker, I don't know if she's pacemaker like rate dependent or if she can override the pacer. So there are certain functional levels of the pacemaker. So she still could have tachycardia, and if she Brady's down to a certain level, the pacemaker would take over. So is it a on demand, or is it a permanent, like rhythm generating pacemaker? I don't know if that's a correct term, but I don't know much terminology for pacemakers. Blood pressure is actually pretty good. We don't have orthostatics, but it's not a low blood pressure, and sometimes diastolic being low can also give you an idea if there's volume, the amount of volume in the vessels after systole. And there's no large pulse pressure gradient, so that's also missing here as well. That could also clue you into low, if there's a low volume state. Patient's not tachypnic. 90% on room air it's meeting the minimum, so that would equate to a PO2 of 60. So I also don't get an idea that there was any respiratory issues from the HPI, so something you also have to consider. And I'll let you try the exam, Nikita, and if you have any questions, I'll jump in.
Yeah, so I have a couple of thoughts. So over here, Dr. Patel did mention that this person was also having some amount of dyspnea. So I'm thinking with this 90% room air, should we also think about the lungs along with the cardiovascular system? And also with the high BMI, does she have a history of OSA? I really want to tap into that, because we see that this person is in a volume overload state because of JV distension. I'm thinking there should be a right heart failure, but there's a holosystolic murmur heard in the left parasternal border. Yeah, so that's making me think of the mitral region. So I don't know. It's a mix because it's going both ways, but I can't really. I don't really know what's what, but I think I'm pretty much interested in knowing what primarily the previous ECGs, if there are, as to why these sinus node dysfunction occurred, and is this a murmur that used to be present before, or is it a new onset of murmur? So yeah, I'm still confused. This is pretty interesting, but let's see where this goes, I suppose.
Oh, very good there. Yeah, the murmur here, as you mentioned, yeah, it with the left side. What do we listen to? Right along the sternal border, maybe tricuspid valve, going out laterally, mitral valve. But what you sort of have to break down the holosystolic murmurs. Usually have to do with, on the right side, tricuspid regurg, left side. Then, as somebody had mentioned, it could be tricuspid regurg or mitral regurg on the left side. But I think the left lateral sternal border would be tricuspid regurg. And it makes sense with the tricuspid regurg. There's pressure that's retrograde and maybe causing excess pressure on the valve and causing stretch and this regurgitant murmur. So could it emanate from the pulmonary vasculature, something like pulmonary hypertension, and then retrograde all the way back on the right side, down the legs, the abdomen? Sometimes you get ascites, hepatosplenomegaly, or congestive hepatopathy, but none of that there. The legs do seem to be associated with this phenomena as well. And one interesting thought also came into mind. Sometimes we do miss pulmonary embolism. So we think about the pulmonary vasculature, pulmonary embolism can cause syncope. So something also put on our list of potential differentials. And yeah, definitely have to take a look at the heart and get an echo to see. And this JV distension also augments this hypothesis that there's a cardiac issue at hand, and maybe the answer lies in the pulmonary vasculature, or it could also be left ventricle involvement as well. So any sort of cardiomyopathy or injury on the left side could potentially cause this as well. So left-sided failure can cause right-sided failure. Anything else? Could there be other layers? We talked about myocardium. How about the pericardium? So some sort of pericarditis, constrictive pericarditis. We didn't hear any pericardial knock or some sort of abnormal sound from the pericardium, which would clue us into pericarditis. But an EKG would be very helpful, I guess, along with labs, and then a echo or POCUS of the heart to see what exactly is going on. Back to you, Sanjay.
Sure. So I can give you just some basic workup in an EKG before we get to looking at the heart. But electrolytes were normal. Hemoglobin was 19 with an MCV of 91, platelets of 137,000. EKG is atrioventricularly paced with a heart rate of 70, which per her report is what the base rate is set to be at. There's some suggestion of left and right atrial enlargement and right ventricular hypertrophy. Interrogation of the pacemaker, which was done in the emergency room and was okay, did not have any abnormalities. A troponin of 37 and a NT pro BNP of 9,900. And then chest x-ray, lung fields are clear. There's some cardiomegaly and the pacing wires in the pacemaker in place.
All right, very interesting. Nikita, does this help any of our diagnoses that we've collectively put together?
So yeah, the most interesting thing over here, first off, is the hemoglobin. It's 19, and you'd expect a 44-year-old female to have be around like 12 to 15. So 19 is pretty high. So I'm thinking, is she in a hypoxemic state? So is that because of the fact that, the BMI is 41? So because of obesity, does she have an OSA, and then leading to pulmonary hypertension, leading to right heart failure? So now I'm able to probably think that, this is what might be the cause. But anything else? Yeah, and even the EKG, I mean, it seems to be in line with the process that I did mention.
I think.
Yeah.
Oh, you're back. You're
And
back.
BNP 9,100 is high. So oh, I'm sorry.
Yeah, we can hear you now. We lost you there for a second. You were talking about the BMP. I'll give her a few seconds, hopefully, to read.
Wondering,
Oh, Nikita, I'll go ahead. I think
I'm sorry.
it's a little
I think,
choppy. Yeah.
You could carry until my connection is back in place.
Yeah. Yeah, Deborah is also having trouble listening to you. Yeah, it's a little choppy, but I kind of heard a few things you mentioned that pro BNP, we are dealing with a congestive state, and that does augment our hypothesis that there's pressure that emanates all the way, maybe starting in the pulmonary vasculature and on the right atrium, resulting in this high pro BNP. So it also may help to get a baseline if this patient has, say, a ProPNP of 300 at baseline. This 9,000 really is a remarkable elevation. Then there's looking at the EKG, there's biatrial enlargement, left ventricular hypertrophy. So it looks like left and right atrial enlargement. The right atrium enlargement would help with, I guess, if there's pressure being generated from the pulmonary vasculature. The left, I can't really tell why it's enlarged unless it was increased afterload, so systemic hypertension, and that also would result in left ventricular hypertrophy, or if there's, say, a valvulopathy like aortic stenosis, increasing pressure gradient across both left atrium and left ventricle. The X-ray shows cardiomegaly, but no congestion. So cardiomegaly, this is all structural changes related to whatever's going on in the lungs. But still, it's kind of murky what exactly may be causing this. We have a couple of thoughts, but I really can't make a real guess what exactly is the diagnosis. But a few things, and I think because this is POCUS, RVH, okay, RVH. So it is all right-sided then. Yeah, that does make sense. So there's some what we call cor pulmonale, and this has probably been going on for some time. You don't immediately start having atrial enlargement and right ventricular hypertrophy right off the bat. This patient's probably been having these pressure effects for quite some time. And AST associated with syncope. Oh, was there a AST? Oh, discussing the polycythemia here. What, Nikita, are you back? Yeah, that was very interesting. And Sanjay had pointed out in the chat that there's iron deficiency anemia, but then a hemoglobin 19. My thoughts exactly, is this a patient that's living at a high altitude or has been chronically starved of oxygen, and this is due to low oxygen tension, or is this due to hormonal effects? Could this be due to medicine? Certain medicines could exaggerate EPO in that case, or could this be something along the lines of secondary or primary polycythemia? I'm not quite sure. Obesity, hyperventilation could potentially also cause this, or could there be some element of humor concentration on top of this? Also don't know, but that definitely stood out for me as well. Anything else, Nikita? I think you're back. I see you back.
I do think the only question I do have in my mind is why does this patient have a murmur at this point of time? As in, we do see that her troponin is 37. So does she have an ischemic event that caused there to be a murmur to be present? Is it there since before, or is it an acute onset? So I'm confused about that, but I do think that we might be on the right track, because we see that she's a chronically hypoxemic patient, and the polycythemia is one way to know that, along with the chest X-ray showing cardiomegaly. So yeah, I'm looking forward to see what's more to be. I'm looking forward for more imaging. So yeah.
Okay, back to you, Sanjay.
So I think here is where an appropriate time to say, hey, let's look at her heart, as you both have been mentioning. So let me make sure that I can share this. Are you able to see the video clip?
Yes, perfect. Thanks.
Okay. I'll focus on the heart. We did a variety of different ultrasounds on this patient, but just some heart views here. So this is and I apologize, I told Ravi yesterday, these are videos on my phone of a video on a tablet, because I wasn't able to import the images. So I apologize for a little bit of the grainy quality of the video, but this is the parasternal long axis view. Hit play here. Ravi, did you want to go through the videos, or did you want me to explain through them?
Yeah, I'll take a stab at it. Just looking here. Yeah, the right ventricular outflow tract does look exaggerated to me. Next coming down, you see the aorta. I see it opening appropriately. I don't see a lot of echogenicity. It's not very bright. It's not hyper intense to suggest something like calcification or stenosis there. And I don't think it's overly dilated. So to me, it looks fine. But then going down to the lower section, left atrium does look enlarged. And then to the left of that, the mitral valve, it looks like the excursion looks appropriately. You see the anterior leaflet hitting the septum. And then the ventricular cavity, let's see. I don't see a pericardial effusion, so I see nice, intense pericardium at the bottom there. So there's no anechoic area to suggest any pericardial effusion. But the squeeze looks, yeah, it looks pretty good, I think. Mm-hmm. Yeah, it's a little thickened, like you mentioned, there's some LVH. But the right ventricle is what bothers me, I guess. That does look large.
Yeah, and I'll just add a great overview, and I would add, just a nice learning point is something we call the rule of threes, which is the right ventricular outflow tract, the aortic outflow tract, and the left atrium roughly should be about the same size. And we can see, in comparison to the aortic outflow tract, here we have the RVOT, which is bigger, and the left atrium, which is bigger. So we know that we have some sort of probable right ventricular dilation and then left atrial dilation. As you mentioned, the squeeze in the LV looks okay. Again, it's slightly limited view, and this is why one view is no view. So we'll look at some of the other views together. So this is the parasternal short axis view.
Nikita, do you see anything there? I know you've done a few of these or been at these POCUS VMRs.
I'm not the best at POCUS, so I will probably redirect it towards you, because I do not really want to make any mistakes when
that's okay.
explaining it.
I want to give you a chance there, but I think Jack and Amir pretty much focused in. We're looking at the biventricular view here. So this left ventricle here, thicker myocardium, again, the pericardium, and then we see the right ventricle right next door to it. But it's like so overwhelming, the left ventricle. The left ventricle should be larger compared to this, and this should be sort of like a half a sort of semicircle, but this is a full circle. It's pretty big. And then I didn't really see if the septum, intraventricular septum, is moving more towards, when there's a lot of pressure, if it's moving towards the left ventricle, compromising filling of the left ventricle. But just eyeballing the right ventricle is massive. Oh, D sign, right? So that would be the D sign, where the, instead of being a nice round shape or oval shape, it's flattened. So that's what they call the D sign.
Yeah, you can see here the intraventricular septum, as folks pointed out in the chat, is the LV doesn't look circular and donut shaped. It looks more like a D, where the septum is a flat line, and then the rest of the ventricle pouches out. So this is a flattening of the intraventricular septum because of the massive size of the right ventricle. This bright little hyperechoic area here, that's the pacemaker lead. And then if you look very closely right on that lower right quadrant here, just right around the left ventricle, it looks like there's a small pericardial effusion. And then this is the 4-chamber view.
Wow, then there again, we do see the right ventricle, but then I see this echogenicity within the right ventricle.
That's the pacemaker
Pacemaker lead. Okay,
Yeah.
okay. There, I'm seeing ghosts there. It seems to be this round object, but yeah,
Sure.
the lead. But then again, the ventricular size is just phenomenal. So it's just remarkable. And then the septum, again, it's encroaching on the left ventricle. Left ventricle looks tiny compared to the right ventricle. And Amir also mentions big atria, right ventricle. Yeah.
Yes, if you look here at the right atrium, you can see it is enlarged. So is the left atrium, but the right atrium is significantly more enlarged than the left atrium. And a good rule of thumb with POCUS, if you're looking at a TTE, the right ventricle is usually no more than about 2/3 the size of the left ventricle. So if you ever start to see the size of the ventricles becoming equivalent, or the RV bigger than the LV, certainly highly suggestive that there's right ventricular dilation, either pressure or volume overload. And then last view here of the IVC, which we can see the IVC is dilated, and as the patient's breathing, not collapsing. And you can see some of this echogenicity, which is actually reflux back into the hepatic veins and reflux back into the IVC, which correlates with the patient's jugular venous distension.
And I guess that last image, I think, who was it? Somebody had, maybe Gigi had mentioned, we know it's the IVC because of the thinner wall, and also if you follow it, it will enter into the right atrium. So you're not looking at the aorta, you're looking at the IVC. That's a massive IVC, and it wasn't even collapsing.
Right. You don't even need to measure that one to know that it's dilated, not collapsing.
So the picture definitely augments what we were thinking, that there's right ventricle issues, retrograde pressures causing the IVC and then the edema in the legs. But then what could cause such a picture, I guess? Is there any more data points, I guess, or any aliquots before the final diagnosis?
I can give you some more diagnostic information. So, initially in the emergency room, CT angiogram was done. There was some concern initially for PE. There was no PE. It did mark that the PA was dilated. There was some cardiomegaly, a small pericardial effusion, which we saw in normal lung parenchyma, and a comprehensive echocardiogram confirmed what we were able to see on point of care ultrasound, which is a massively dilated RA, RV, There was a moderate amount of tricuspid regurgitation. The pulmonary artery pressure was approximated to be about 80 millimeters of mercury, and the LVEF was grossly around 50 to 55%.
So this looks like a case of pulmonary hypertension, I think, Nikita. Any thoughts?
Yeah, I mean, should we relate this pulmonary hypertension to be due to the fact that she is obese? Would we relate it to that? But also, it makes me wonder about how's the workup like when she was diagnosed to have sinus node dysfunction? As in, I'm not able to correlate her presentation now to her past medical history. So if you were to explain how this takes place, that would be great.
Yeah, the causes, I guess we usually run through the WHO criteria, with one being the vascular disease. So is there autoimmune phenomena? Is the answer in the vessels? 2, is it cardiac? 3, is it alveolar related, the lungs? 4 is CTEPH. I guess 4 looks like a leg, and 5 is everything else. So I mean, connective tissue disease comes to mind. That would be something also in this age range that we would think about. But yeah, OSA definitely can be a cause. But then again, we would have to call for expert help. We've got to this juncture now. We know why she has edema, why she's having this syncope. I always look for PEs because I've seen that, and there was an NGM article study done in Italy where they found patients presenting to the ER with syncope. They found a good number having pulmonary embolism, so they wanted us to put that on our differentials when admitting somebody for syncope. But now we'll have to consider all the other potential causes, like Jack has mentioned, so chronic hypoxemia. And then this polycythemia also correlates with that chronic hypoxemia. So that could be in response to that hypoxemia that she has. Sanjay?
Yeah, no, wonderful thoughts. And, that was the thought here, is that this is pulmonary hypertension, but the question from what the symptoms seem to correlate, if you go back to some of the chronicity of the symptoms. And so in a pretty thorough evaluation to try to determine what the etiology was, patient was HIV negative, ANA and ENA negative, hepatic function tests with an ALT and an AST that were mildly elevated to the 40s, and a BILI of 1.7, and a liver ultrasound, which mentioned fatty filtration, but no obvious cirrhosis. So it kind of does in line with thinking about type 1 disease. Type 3, she had a pulmonary function tests that were normal, and she had a polysomnography, which mentioned mild OSA, but not severe. For type 4, for CTEPH, she had a VQ scan done that showed some small, very peripheral, symmetric subsegmental perfusion defects, but nothing obvious. And then ultimately, as some folks mentioned in the chat, had a right heart cath. So the mean pulmonary artery pressure on the right coronary angiography was 67 millimeters of mercury. The wedge pressure was 13, which is normal. There was no vasoreactivity, and the PVR was 21 Woods, which is extremely, extremely high. And so ultimately, it was felt, her diagnosis to be type 1 pulmonary arterial hypertension, either of the idiopathic or the congenital variant. She was started on tadalafil with plans to arrange for outpatient prostaglandins IV, and had a home oxygen evaluation while in the hospital.
Wow, incredible. So all these syncopal events were related to this ongoing developing of pulmonary hypertension.
Yes, and Nikita asked a little bit earlier, was there any correlation to her previous history? Based on anything that we could determine from her and any sparse records that we have, they seem to be true and unrelated. The initial causes of the syncope and the AV node defect seem to be some sort of conduction issue. And this seemed to be significantly a second primary process. Sounded like she had a lot of evaluation up front in terms of what you both mentioned, like infiltrative diseases and things like that, which never seemed to come to fruition.
It was interesting with syncope when there is a presentation. Sanjay is also a hospitalist like I am, and we're always getting hounded about unnecessary echoes and just doing an echo right off the bat for a patient with syncope. You could potentially call or catch this in evolution if there's increased pulmonary artery pressures, but otherwise somebody coming in with syncope, it's not really recommended unless you have like new onset congestion, EKG abnormality, suspicion of structural cardiac disease, a murmur as well. Maybe 3 out of 6 is what I've read. So there's certain guidelines where they recommend echoes. So I wonder in her workup if it was done, but with this presentation and peripheral edema, this was JVD, an echo was necessary. But we do a lot of high value care, cost effective care, and echoes are not always done, just like carotid artery duplex and EEGs and things like that, CT head, unless there's neurological deficits. So a illness that we're diagnosing more and more, understanding more and more, and sending to specialists. Something very interesting here. I really appreciate you bringing this, Sanjay. Very important case, something we should look for as we do have an obesity epidemic. And I think this is not really thought of as much, or we try and tackle cardiovascular disease, but not pulmonary hypertension. Nikita, any reflections?
Yeah, this was an amazing case because one thing I realized that there were so many factors that could have progressed to cause pulmonary hypertension, but yeah, and we finally got it to place. But this is great. I loved learning this. I think I'd have to learn more about pulmonary hypertension in general, because recently we've been seeing a lot of the same type of cases being discussed on VMRs too. So yeah, I'm so grateful that I got to discuss this case with you both. Thank you so much.
Yeah, thank you, Nikita. Great job. And I really, again, appreciate you, Sanjay, for bringing this case. This was a gold mine of a case, and spending your time with us this afternoon.
And I think one thing that I will stress is, with point of care ultrasound here, it didn't necessarily give us the ultimate diagnosis, but I think in the interval period, it helped us triage what was going on, kind of come up with an interval diagnosis, and helped us start to prioritize what our next steps were. So we were able to start evaluating and getting workup in motion prior to ever getting the comprehensive TTE, because we had put all the pieces together and had an idea of what might be going on.
Yeah, and what I really like now, Sanjay, with these POCUS VMRs, I'm seeing in the chat people starting to interpret the ultrasound images that you all bring. So I think our learners are becoming well versed in point of care ultrasound. They just have to now concentrate on image acquisition, but interpretation they're getting more confident in.
Absolutely, great job.
Yeah, thank you again. Leah, teaching points, please.
Yes, thank you for this case, and I also agree. I think because we had, I think the rule of threes, for example, we had that several times already, so it's getting easier to pick that up. And I actually think it gets more and more fun when you see things that you can now recognize. So for the teaching points, we started off with kind of talking about syncope and thinking about what are the different causes. In this patient, we pretty quickly started to prioritize cardiac causes, but we can also think of orthostatic or vasovagal causes of syncope. And in order to know where to put your cognitive energy, and you can look for associated symptoms. And things that might be clues for cardiac syncope are, is this an exertional symptom? Or does this patient have a low volume status, and might this be orthostatic? A reflex or vasovagal sympathy syncope is usually associated with a prodrome. And then you can also think of mimics to differentiate, okay, is this really syncope, or might this be a stroke or a seizure, or hypoglycemia that mimics this? And then we talked about differential diagnosis of arrhythmia that can also be causes of repeat syncope. And then Ravi mentioned ictal bradycardia as one of the causes, which is a seizure-associated condition, and you treat that by treating the epilepsy. And then other arrhythmias are the Brugada syndrome, long QT, infections might be a cause, or infiltrative diseases. And especially with this patient, also I found a great point Nikita mentioned was to consider looking at previous ECGs or examinations or lab values to kind of help yourself orient and prioritize things. And then I want to jump to the different images that we viewed, and again remind us that one view is no view. That's why it's always good to have different views. And the rule of three, which is applied to the peristernal long axis view, is means that the right ventricular outflow tract, the aorta, and the left atrium should be around the same size. And if one of them is bigger, then that is an indication that it's dilated and is an abnormal sign. In the peristernal short axis view, in this case, we saw the D sign, which is an indication of an elevated right ventricular pressure. And the septum is flat instead of more round and bulging out of the left ventricle. And then we had the apical four-chamber view. And normally, the apex of the left ventricle is larger and should be closer to the probe. And when the right ventricle is higher, that's already an indication that the sizes are not as they usually should be. And Dr. Patel told us that the right ventricle is maximum of 2/3 of the left ventricle. So in this case, it was a clear right ventricular dilation. And one thing that I thought was really cool is to think about the JVP as the clinical exam finding, and the IVC distension on echo kind of the continuation of that. So it's always good to confirm and complement things with the different modalities you have at hand. And finally, we had the diagnosis of pulmonary hypertension, which can be classified into 5 subgroups. And clues that might show you in this direction is signs of right ventricular strain on the ECG, and then also on the echo, but the diagnosis is made by a right heart catheter. And the 3 important values that are looked at is the pulmonary artery pressure, the wedge pressure, and the pulmonary resistance, the vessel resistance, exactly. So that was a short recap of the case today. And I want to thank you again for bringing this case, and for you, Ravi and Nikita, for discussing and having us learn together.
Leah, that was fantastic. You were like, just hearing you, I like hearing a POCUS expert. Your use of terminology is just so great. Thank you, everybody. Thanks, Leah. Thanks, Shema, for scribing. Thanks, Nikita, for co-discussing. And thanks again, Dr. Patel, for coming on and sharing this fantastic case and also teaching us about POCUS. Take care, everybody. Have a great rest of Tuesday.
Take care, everybody.
Bye.